So thanks to the National Working Group for the invitation. I'll make some apologies to start off with if I use any Australian phrases, or if I talk about cricket more than I should talk about hurling. I'll apologise for that. I was coached before I did my interview when I came back that I should not talk about hitting things for six, etc., etc. I always thought that it was important that when you come to speak at events like these, that rather than focusing on the fact that I've been in Australia for 10 years, that I actually have a good appreciation for what happens here. I've worked in the Mater, in Our Ladies in Navan, in Louth County, in Wexford General, in Cork University, in the South Infirmary, in St Finbarrs, and the Royal, St Colmcille's, and the Royal Hospital in Donnybrook, and St Vincent. So I have a good appreciation, although I'm 10 years out of date at this stage. I went to Australia in 2007, and I've spent most of my time in Sydney Local Health District. This is where I spent most of my time in Concord Repatriation General Hospital. We dropped the Repatriation General a couple of years ago when we went through rebranding, but essentially it used to be an old repatriation hospital for returned veterans, and so there's quite a draw of an older population as well as the local government areas that are covered by the hospital. It's a 500-bed Sydney University teaching hospital, and we've got the State Burns Unit and a number of other subspecialty quaternary referral services, but we're tertiary referral for a number of outlying areas. And a number of world-renowned research institutes are attached to the hospital. Some of the more eagle-eyed among you might recognise the hospital from that particular picture, because it was also the location setting for All Saints. So those tragics of medical dramas in the 90s will remember it. And I left St Vincent's when they were filming for the intern programme, having to dodge them when I'm coming out of the res at 2 o'clock in the morning to go back to the emergency department, and then met them in Concord and also had to dodge them when they were doing location shots, otherwise I would have been in the background. It's also really important when you're trying to look at what has worked overseas to what will work in Ireland, and know what we're talking about. So this makes a really lovely tea towel. Australia is bigger than Europe, all of Europe. So that's the first thing to think about. So we have most of our population is concentrated in an area in this boomerang coast from Brisbane all the way around to Adelaide. That's where the vast majority of people in Australia live. So to think about things that work, say from a UK perspective, being translatable to Australia won't always be the case. And there's a big difference between what will work in metropolitan centres and what will work in regional and remote areas. I've spent most of my time in New South Wales, which is the largest state in Australia, and has the highest population and also the highest per capita population of Aboriginal and Torres Strait Islanders. So there's some cultural and geographical idiosyncrasies to the state as well. This is Sydney Local Health District. It's about 127 square kilometres of inner western Sydney. It is not beside the beaches. It's going up towards about 600,000 of a population, and well over half of them speak another language other than English at home. So a huge cultural diversity. It's also a very aging population at the moment, but we're going through quite a structural change with lots of land release and increased in high density living, so much so that what's projected up to this point may not be what's projected for the next 20 years, where there will be increasing need for paediatric and maternity services. But essentially about 10% of the population is over the age of 70. And over 65-year-olds account for over 50% of admitted patient bed days. So there's a big proportion of older people, and they use a lot of services. We've got 4 main hospitals. Royal Prince Alfred Hospital, again, some people who like reality TV will know it from its TV program, where it walks you through different services. Is the largest hospital. It would have neurosurgical, cardiothoracic transplant services. Concord would be its sister site, and then we have a smaller general hospital at Canterbury, and a more subacute hospital at Balmain. And they're spread into actually the 4 corners of the local health district, which can then raise problems in terms of access. It's also really important to understand what funding arrangements are in Australia. So it's made up of a federation of states and territories. So the federal government has the biggest pot of money. The state government can also derive some funds. The federal government will pay for certain services, the state government will pay for others, and there can be a real tension between both of these. So say, for example, 80% of funding for acute hospital sector is under the control of state governments. Whereas if you go out into the community, that's under federal funding. So if we needed more community services to help remove patients from hospital back to their home setting, there is a direct tension between who's going to pay for that. And then at times we'll have the Council of Australian Governments, where we'll have federal government sit with all the state and territory governments and agree some special funding arrangements. And that can go into some special projects, and I had some funding through that mechanism. I thought what was probably most appropriate is take you through a journey for Nora if she was in the inner west of Sydney. So just to set the scene, she's 75, she's pretty robust, so she's still out driving, she's independent with her care and some of her personal, her domestic chores. She's got a limited medical history and a pretty conservative amount of medications. And she'd be described as cognitively sharp. So she's a pretty robust 75-year-old. So from the outset, she could access certain services. So she could be involved in some healthy, active aging, exercise classes, day centres for socialisation, monthly bus trips. Some of these were under the control of local governments. So the Canada Bay, Strathfield, Burwood, Ashfield, Marrickville, all those local government areas would control some of those services, and they would produce a booklet and tell us what we could avail of. The booklet was serially out of date. It then went out of print, and no one thought that it was useful, except I kept using it. She could avail of community-based education sessions, so we had a strong program of volunteer and community services like Probus or the Lions Club or the Rotary Club, who would have drawn people in and actually asked me as a medical professional and some of my colleagues to attend education sessions and run education sessions. And with a very strong veteran population, we also had Veterans Health Days, which was very important for me to be able to sort of hone my technique in terms of giving information to people in a plain English sense, and also to understand what their requirements might be from a service. She could also avail of an in-home pharmacist medication review. So a pharmacist would go and attend her house, and she would clear out, he or she would clear out all of the spent medications and look at the sensibility of prescriptions that they were receiving. And she could also access single service purchases of community services. So maybe she would want domestic assistance once a fortnight for the heavy domestic jobs, and she could pay for that on a per hourly basis. Then Nora had a fall. So depending on how significant this fall was, Nora could access different services. There was a big program to develop health pathways. So what a health pathway was, suitable for community and general practice or primary care services, to go into this online service that was run through our local health district and go, okay, my patient has had a fall, what should I do next? And then get guided through what they should think about accessing, and then specifically when they should refer to hospital-based services. So she had an injury where she had, so she had a fall with no injury and preserved function. Stepping On was a class of 1-hour sessions over 7 weeks. We had language-based or language-specific sessions, and that would teach you falls prevention tactics for the individual. She could get balance exercises, and some of these were through private providers. They would send us information about it, and we could pass that information on, or they had advertising through local media. And then healthy aging exercises that were run by local government. If she had a minor injury and she was at high falls risk, she might then need to access our fall service, which provided home-based physiotherapy and access to a geriatrician comprehensive review, or she might need to have admission to hospital. And we could avoid hospital admissions by having a rapid access to geriatrics clinics or home visits. But we also sometimes needed to access other services, like rapid access to respite services, or to bypass being in hospital and go straight to subacute care. If she was admitted to hospital, she could access Compacts, which was a community package that lasted 6 weeks. It was free to the user, and it provided her with services for support but no allied health component. If she was admitted to hospital, she could access a transitional aged care package, which provided her with 12 weeks of allied health input and services. That had a $60 per week fee, and to give you some sense of how that sort of sat in a scale, it would have cost about $120 per visit for one physio visit. So that was really quite cheap, and the physiotherapist or the occupational therapist could have gone to see her more than one time. We had a strong private approach to healthcare, so there was private rehabilitation if she had private health insurance and that private health insurance covered rehabilitation. She could have private home-based physiotherapists, so lots of private providers went to patients' homes and provided care. She could also purchase 5 sessions through an enhanced primary care initiative, so the GP could access this reduced cost private physiotherapy. And then we've used at times respite and residential aged care facilities as a convalescent period, and that cost 85% of your pension per week. So that was a considerable financial commitment. Now, how did you access these services? Well, we developed an aged care triage service that sat between, it was under the governance structure of the local health district. It was staff that had worked with the aged care services previously, and it worked at its best when we had staff that had been there for a while and had worked in the community and then transitioned. So they actually had a good idea of that spider's web network of services. When they were very well in tuned with things, they could actually direct patients to what they might require that may not be hospital-based services. So GPs made referrals, community services made referrals, hospital services made referrals, private providers made referrals, and patients and carers could make referrals. And then they were triaged to what was appropriate. So from a hospital-based perspective and private providers, so if you were in an inpatient in a private rehabilitation hospital or a private hospital, you were considered to be an inpatient for the access to these services. You could get that compact service, the TACP service. You could access clinics, you could access geriatrician visits, you could access home-based therapy and the full service, and you could access the aged community assessment team. So they were the people who I think most closely aligned to public health nurses in terms of their assessment for community services and the need for residential care. Now, Nora transitioned into moving into a residential aged care facility, and then she became unwell. So at that stage, we could still access different services. So GPs and nursing staff, patients and their carers could go to the aged care triage and say, this is what's happening to Nora now. They could seek advice, they could request admission, or they could request an urgent residential aged care review. And both the seek admission and seek advice and assessment in the residential aged care facility were designed as hospital admission avoidance tactics. And they did and didn't work at times, depending on the needs of the patient. So for Nora, she had an assessment, she could have had an assessment with our residential liaison team. So that was both nurse-based and medically based. And depending on what was required, she could have had care continuing in the residential aged care facility. We were extending our hospital and the home service to provide outreach into residential facilities, so she could have intravenous access to fluids, intravenous antibiotics, replacement of urinary catheters, peg feeding tubes, that sort of extent of service. Our residential liaison service had a very adept advanced nurse practitioner at wound management, so there were often times where we could avoid admission with good, careful observation and advice for nurses in aged care facilities on the management of wounds. And then if there was an ED attendance required, we could actually have them met by our age service in the emergency team, so nurses who were trained in geriatric medicine, in gerontology, to catch those patients that might have a quick turnaround if they were dealt with appropriately. So I always keep in mind a story of a gentleman who would thrash out when interventions were attempted, but he loved ice lollies. So Sue would rush by the ice lolly, hold his hand, give him the ice lolly, no problems with interventions. So that sort of core knowledge was really essential. They also would then give advice that would travel up the house in terms of delirium management, falls and pressure area care, and some of the social and individual knowledge that they would have gained over multiple interactions with patients. So integrated care fitted in the community with health pathways, with our central triage, with community-based programs, in our residential aged care facilities, with our residential liaison service, with hospital in the home, in the hospitals with early supported discharge services, with age services in the emergency team, which in some ways mirrors some of the FIT services, but not quite, and then rapid access to geriatric clinics or domiciliary visits. What we did well, I think, was the centralised referral system, especially when we were in control of who was there. So if I had had a call from Karen, and Karen had worked in our service for quite a while, I would know that she really understood what was out there and that she had tried every other available alternative than to either admitting the patient or asking me to admit the patient or ask me to go and see them at home. We had lots of early supported discharge options. Some hospitals used them better than others, and some patients knew the system. And so they would not pay for the $70 or $60 a week service and then want to cobble everything together with other free services. We had early input in the emergency department in the management of frail patients as much as possible, and we had the start of admission avoidance. What we could have done better is our asset team only worked from 8 a.m. to 7 p.m. and I know I say only, but they could only see a fraction of the number of patients that were coming into the hospital. We did have at times an expansion of funding that allowed us to extend into the weekend, and other times where it had to contract. So anybody who's worked in services where funding is pulled will understand how frustrating that can be. Long waiting lists for TACP, so it wasn't really early supported discharge anymore, and access to rapid access appointments could sometimes be delayed depending on annual leave, the amount of cross cover that was available. There was always poor communication between some residential facilities and services. So along the way, we had a change in government, services started to get centralised. They would have a centralised phone number to call. They would then have things repeated because there wasn't the local knowledge being fed into the system. And so we might have been asked to go and see someone who we knew very well or had had problems before that would have been best directed to us at an earlier stage. Funding, and I'll put that there, and I probably won't need to say anything more about that. Silos, we still tended to have problems with communication and that tendency to want to just sit within your own area and not know about what's going on elsewhere. And there was a very limited use of hospital in the home in the residential aged care facilities, and repeatedly we'd still have people coming in to the emergency department, I would have said unnecessarily. No integrated care service developed in the same way. So Sydney is big, it's got a 4 million population, which is increasing exponentially. What suited the inner west of Sydney, and I'm trying really hard to find an area that sort of mirrors it, but it probably Drumcondra and Clontarf is kind of that sort of, you know, we've got organic health food shops and, you know, a mix of social and economic classes within the area. It's not the eastern suburbs, which are, again, high earning capacity areas, but we're not the south of the west of Sydney, which is a high immigrant population and low earning potential. And there wasn't a standardized approach to everything, so we might have been given money for an asset team, so the emergency services, in age services in the emergency, and you weren't told how exactly you needed to spend that. What we could replicate here, I think very easily, is centralised referral systems for older persons. So we do that in an ad hoc fashion, I think, in some ways. And there's a difference about what you obtain for community services, as opposed to what you contain for hospital-based services. And maybe it needs to be wider in terms of a local health district approach. We need to advertise existing services, and I mean, I've only been in the job for a month, and I still am finding more and more things that are actually existing and how we get to integrate that into what we do every day. We need to build better communication strategies that go from the top down. So if I go to a high-level meeting, I need to say that to the team I'm working with, and also if they find a problem on the ground, they need to tell me so I can feed that back up the chain. We need lateral movement in information. I know I sit within community services where there's existing community allied health. Do they know what we do? Do I know what they do? Extension of existing services. So if CIT works very well in County Wicklow and CH06 actually covers Wicklow, why can't we use CIT in the Greater Dublin area? And I think the longer I stay in medicine, the more I get to revisit things that were old and now new and now old, and that's intensely irritating. Understand what worked and why. So I know that the Beaumont service of FIT has worked incredibly well there. Why has it worked? I always reflect back on a talk that was given by Dr. Frances Healy, so a nursing researcher in the UK, and how some services are driven by personalities, by key change makers, and that can't be replicated elsewhere. Or these people are poached. They're really good, they get things done, and then they suddenly get moved or seconded into other services, and that happened all the time in Sydney. Understand the needs of your community. There's not much point in having something that's accessible within 30 minutes if it actually takes you an hour to drive from one end of the service to the other. And avoiding duplication. So we ran into trouble with our falls service because the home-based therapy physiotherapists didn't know why there needed to be a falls physiotherapist, and vice versa. And then be creative, and I'm going to give you one last picture to look at. This is Professor Len Gray. So he works in Brisbane in the University of Queensland. And he has pioneered for Australia remote health technology. So this is, the top picture is what Len likes to make it look like, you know, in his, you know, nice, calm surgery, where he's actually doing an assessment with a patient who's in Roma. Roma is 4 hours drive away from Brisbane. Roma could not recruit a geriatrician to be there full time. So they had to be creative about what they could do. So Len is actually assessing a patient like he's doing a virtual ward round. The bottom picture is what it looks like for the patient. So Len is being wheeled around as a bobbly head on a computer screen. And I always worried that that would make delirium worse, like they're having visual misperceptions, but actually it works really well for them. And it means they've got continuity of service. And I think there's certain elements of that that will work here. Particularly, I happened to be between sites during the week, and I knew it was helpful for me to have been in the emergency department. And how was I going to replicate that? Can I use Skype to Skype for a patient in the emergency department? What are the actual technology restraints as far as that's concerned? What are the infection control issues? Wipeable surfaces, does a tablet, can it be wipeable? You know, and it's really important for that continuity of care, for them to see me, to know me and talk to me, so that they trust when I send someone out to them, that they have that link, and the link is there from the emergency department into the community and back again. And I think I'll leave it at that.